Good afternoon, friends. Myself, Dr. Gururaj Sangondimath. I work as a senior consultant in unit head spine surgery at Indian Spinal Injury Center, New Delhi. At the outset, I would like to thank ASSI for giving me this opportunity. So this is a 32-year-old female who presented with back pain and with bilateral lower limb radiculopathy since 4 months. Left lower limb pain was more than right, and weakness in the left foot since last 15 days. And she also had hesitation in urination. On examination, there was a midline tenderness at L4-5 and L5-S1. SLRT was 20 degrees. The EHL and FHL are both 3/5 on the left side. Sensory decreased at S1 on the left side, and PAS, VAC were intact. This were her MRI. You can see that L5-S1, there is a large extruded disc. So the first part of this video is going to be animated because I wanted to save time. So for initial few cases, you can have your levels marked, the midline marked, and the length of the incision marked depending upon your size of the tube. And this line where you are going to take the basically entry. So it is usually corresponds to 2 centimeters from the midline or 2 finger breadths from the midline. But it all depends on the structure of the patient, the build of the patient. And once you mark that, you start putting in your first initial dilator. Some people try to do it with the guide wire, but I would prefer not to use a guide wire because sometimes it can pierce into the basically interlaminar space and cause dural injuries. So I start with the smallest dilator. And as Dr. Vishal was showing you already, the docking point is lamino-pars junction at the concerned level. And once you dock that, you actually wiggle the basically dilators to separate the muscles from the spinous process and from the lamina. And then you'd go on dilating with the serial dilators. Each dilator is a color coded, and how much basically diameter dilation you do depends upon what is the size of your tube going to be. I usually use a 18 millimeter tube. And then the dilators also have a length marked on them. So you can use a 5, 6, 7, 8, depending upon the depth of your basically the lamina from the skin. So once that is done, you connect your basically the flexible arm to the tube to hold it in its place. And whenever you do this, you try to preload the tube by taking your flexible arm upper level or above the basically the tube so that it stays down and it doesn't come out or it doesn't try to pop out. So that prevents basically the muscles entering into your surgical field. So once that is done, you can either use a microscope or either you can use a light source depending upon what kind of tube you are going to use. So once that is done, I usually try to feel with my finger inside whether exactly I'm at the right place or not. I try to feel the basically interlaminar space and the edge of the lamina and maybe on the sides, the facets. So once that is done, you will see invariably some muscles creeping into your surgical field. Then you can use a bipolar cautery and take them out. So once that is done, this is the typical field you will see. That's the head end. That's the lateral portion. That's the foot end. And that's the medial portion. This is the lamina. That's where the pars is there. This is where the facets are. This is the interlaminar space. So once that is done, you will start actually separating your ligamentum flavum from the undersurface of the flavum. So how much of the basically the lamina you are going to cut, it depends upon the level of the discectomy which we are going to do. L4-5 and L5-S1, they don't need too much of bone to be cut. But then as you go higher up, L3-4, L2-3, you need more bone to be that laminotomy to be done to access into the disc. Sometimes you might want to do at L5-S1 the inferior laminotomy so that there is a insertion of the lamina is much lesser there as compared to the superior lamina, so that you don't cut too much of bone there. So basically minimizing the bone cutting is to decrease the fibrosis which happens after surgery, and also to minimize your basically ligamentum flaum and exposure of the thecal sac to minimize the fibrosis. But you have to be always wary about your pars there. Don't excise too much of your lamina and then pars, causing iatrogenic pars slices. So I typically use 30D diamond burr for this step, but here for the purpose of making it simple, I'm using Kerrison rongers. You can use either 2 mm Kerrison ronger or a 3 mm Kerrison ronger, depending upon the level and how much of stenosis or how big is the disc at that level. Once you do laminotomy at the upper level, you start doing actually cutting the medial facetectomy to basically expose the nerve root which is required. Otherwise, if you do a too little medial facetectomy, you will have to retract the nerve too much, and then which can lead to worsening of neuro deficits. So once you do that, you start seeing this yellow ligament there. And how much you cut on the medial facet, it all depends again on the basically you should start seeing basically ligamentum fluum separated from the medial facet there. So that's the ligamentum fluum. So how to get rid of this ligamentum fluum, it depends on different techniques. Some people go higher up to the where the insertion ends on the basically lamina, or what I do typically is, because I do very little laminotomy at the lower levels, I tend to basically dissect through and through the mid substance of the ligamentum fluum with a Penfield number 4 or number 3. You can see once we do that, you start seeing there basically the thecal sac, and then you be careful at this step. Once you do that dissection, you actually put your curette or with the Penfield itself, try to release if there are any adhesions between the ligamentum fluum and the thecal sac. Otherwise, you can have a incidental durotomy there. So you start actually doing a flavectomy there, and then you start seeing basically the epidural structures. So the best marker is the epidural fat, but sometimes if your disc is too big, you won't see epidural fat. But if your disc is not very big, then you can see epidural fat. If there is too much of epidural fat, it is also sometimes very troublesome because you don't see structures properly at that level. So then you might have to actually dissect through this epidural fat. You can either use a pituitary to actually slowly pull it out and coagulate simultaneously with the bipolar cautery, or you can use a hydrodissection to basically dissect through the epidural fat. So you start seeing your thecal sac, and basically here there is a nerve root which you have to see it clearly before you start doing your discectomy. So with this Penfield, what I'm trying to do is trying to identify the nerve root. So nerve root is here now. So once you do that, you start retracting your nerve root gently. You have to be very careful. Again here, the nerve root can be sometimes stuck to the disc there. So you have to be very careful when you do this step. And you can use your nerve root otherwise to release these adhesions and then retract the nerve root. So that's where you can start seeing the disc bulge there. Clearly, it is visible. The best identification markers for you are at the right plane is these epidural veins which are seen there. Once you see these epidural veins, it is actually you are confident that you are into the epidural space there, or on the disc. You are on the disc. So once you see that, you start seeing this in this case, it's not always that you will get this disc so easily, but because this is a big and extruded fragment, once you start doing that basically retraction of the root, the disc starts delivering itself out and can see. But as soon as you see the disc, don't be over excited to pull it out. Try to basically take it out in one piece as much as possible. So once that is done, you basically tease it out with the nerve hook, preferably with the ball tip nerve hook. And in this case, actually, once you are teased it out, the one fragment it came out. So taking out it with the pituitary there. So you have to be very careful at this step. don't inadvertently catch the nerve root, or otherwise for beginners, it's always better to be or prudent to be retracted this nerve root always by your assistant, or you can use a suction retractor as I'm going to use in this case. So once that is done, you can see that once the initial fragment has come out very nicely, the nerve root is breathing and it's pulsating. And this is a second fragment which is coming out. So that's the suction retractor. And then I'm going to pluck out this second fragment. So once you take out significant amount of the extruded fragment, the best sign of your completion of discectomy is actually once you start seeing increased epidural bleed or a bleed from the disc, which you're soon going to see here. So you have to be careful in retracting the nerve root. If at all you have to retract the nerve root for a long time, you can relax the nerve root in between, because if you keep retracting nerve root for a long time, then you can have neurological worsening. So you can in between actually relax the nerve root when you are not doing anything around the nerve root there. So if you see there, that's what I was talking. You can see that bleeding from the disc space there. So you can do a intradiscal work, or sometimes if you're confident that the extruded fragments are out, usually I avoid doing a deliberate iatrogenic annular rent until unless I see an annular rent, like in this case where I have not caused an annular rent. And then for loose fragments, you can actually do a hydrodissection by putting a suction cannula into the disc and forcing saline through it. You can actually flush out the loose fragments from the intradiscal level. So once you are satisfied that you have taken out all the basically fragments by multiple, basically you can use forward pituitaries and straight pituitaries, and then you just check for nerve root mobility. And nerve is, you can clearly see the nerve root is pulsating, and it's very well visible. Thank you.